India, along with few other Asian countries, are in the middle of third ROP epidemic. This is because of improved neonatal care, where premature babies have better chances of survival even with lower gestational ages. It was estimated in 2010 that 53,000 babies developed treatment requiring ROP in Asia, of which 20,000 were survivors with severe visual disability and blindness. In 2010, India had the highest preterm births in the world, which is over 23% of the global total. The number has been ever rising, increasing the burden of neonates who require ROP screening. Financial constraints of developing economy such as ours prevents the allocation of large amount of resources for this blinding disease, and ironically, blindness adds to the economic burden of the country. The All India Ophthalmic Society has over 23,000 members, of which less than 1% are involved in ROP care. The paucity of ophthalmologists who are engaged in ROP screening and treatment is reflected on the members of the Indian ROP Society. There are more eyes that need screening and less hands to do it. But this number can be expanded by changing one's mindset. While ROP screening does require training and expertise, innovative alternate arrangements can be done to address and aid this emerging public health problem. This brings me to the topic, the journey of a vitreoretinal fellow in ROP screening, a fellow's perspective of frugal imaging method for ROP screening. As a vitreoretinal fellow in a tertiary eye care hospital that is actively involved in screening of ROP, we are given 1 month training in ROP screening. Our pediatric retina department is equipped with fundus imaging devices that capture crisp images of seemingly rare pathologies that leaves us fellows and residents awestruck. These devices are expensive and are not for personal possession. At the end of the training, we are sent to local NICU for screening of babies on rotational basis. We are equipped with indirect ophthalmoscope with which we examine each baby and refer if treatments are required to the base hospital. It becomes difficult when we are in doubt or when documentation and counseling is required, as we don't have fundus cameras. My zeal to document findings for academic purpose made me design 2 instruments as an alternative for the red cam and the slit lamp. Those were the Trash to Treasure red cam and anterior segment photography with the intraocular lens. The anterior segment photography with the intraocular lens, or as it is called ASP, is a device which will help us make your smartphone a macro photography device. It requires a chart paper to which a double-sided tape is attached, and with the help of a puncher, a small hole is created onto which a 15 diopter lens is stuck and sandwiched between the chart paper. Once that is done, it is attached with a micropore on top of the smartphone camera. This device would only cost you $2.5 or 200 Indian rupees. The Trash to Treasure red cam can be made using a 20 cm long hand sanitizer bottle in which the bottom is cut along the lines shown, to which the 20 diopter lens will be attached to, and the other side the smartphone is attached. You can also add a black chart paper to reduce the reflectivity inside the Trash to Treasure red cam. This device would cost you only $7.5 or 600 Indian rupees. These instruments were taken to each of my NICU visits. After a thorough hand wash and after instilling topical anesthetic drops, all the babies were screened for the anterior segment using the ASP device. The flashlight is turned on and a video is recorded of the anterior segment by approximating it to the baby's eye but not touching it. Fundus images were obtained using the Trash to Treasure red cam by turning on the flashlight and focusing on the fundus of the baby. Indentation can also be done to acquire images of the peripheral retina. This is an image of tunica vascular lentis taken using the ASPE. And these are images taken using trash to treasure REDCam. Zone 2 stage 3 ROP, Zone 2 stage 2 ROP, Zone 2 stage 3 ROP, Zone 2 stage 1 AROP, 3 plus Zone 2 stage 2. During the 1 month training period, I had been to 10 ROP screening visits. The total number of babies screened were 149 with a total number of eyes of 298. 65 males and 84 females were recorded. Mean gestational age was 30.92 weeks and the mean birth weight was 1350 grams. 8 zone 1, 252 zone 2, 38 zone 3 were recorded. 25 stage 1, 8 stage 2, 4 stage 3, 6 plus or ARP were recorded. 6 babies were referred to the main center, of which 2 babies received lasers, 3 babies received anti-VEGF injections, and 1 baby was observed for progression. All the treated babies showed regression with no complications. The images of these devices aid in real-time documentation and display. The images were very useful in counseling the parent or the guardian. It also helps us make them understand the severity of the disease and the treatment options required for it. It also helps us make them understand the need of follow-up and visit to the base hospital whenever required. Sharing the fundus images and for follow-up of progression, regression and severity becomes much easier. It helps in sensitizing the pediatrician and the NICU staff about the disease and also helps us as a teaching tool for residents and fellows. It is a cost-effective, do-it-yourself, easily portable device which can be used by anyone. By this process, we have more hands in screening more eyes to filter necessary referrals. So now we can do our part by reducing the burden of ROP related blindness by helping the 1% ROP experts. This is my idea of bridging barriers and breaking boundaries for ROP care. What's yours?